So I'll open up this session, Men and Blood Clots, a new session for Thrombosis UK, which we're very excited to be able to deliver. And we can only do this with the help of this great panel. So I would like to welcome Dr. Will Lester, who's a consultant in thrombosis and hemostasis and is based in Birmingham. Clinical psychologist Professor Paul Bennett, who is now working with Thrombosis UK, and patient advocate and past trustee of Thrombosis UK, Sean Kinghorn, who are here to share their information, their knowledge and their experience, and also to welcome questions and comments from yourselves, the audience. You'll see in the toolbar, there is a Q&A button and also a chat button. Please do feel free to use either of these to send in your questions or your comments, and as a panel, we'll do our best to answer them as we progress through. We've got an hour, so we'll try to make the very best of it. Can I just, though, draw your attention that the panel can offer general replies, but they're not able to answer very individual or specific questions because those are best discussed with your own doctor and healthcare teams. But they will do their best to answer as many questions as they can. So without any further ado, I'm going to pass over to Sean, who's going to give us a little bit of the background and what brought him to this place. So thank you. Over to you, Sean.
Okay, thanks very much, Jo, and thanks for the invitation to deal with a very exciting and a novel topic, as it were. First of all, a bit about me. I'm 63-year-old. I'm married to my wife, Melanie. We've been married for over 40 years. I'm now retired. We have 5 adult children who have thankfully flown the nest. And are relatively independent and have a number of grandchildren. And as you can gather from the accent, I'm from the northeast of England, Vera country, for those who are familiar with watching the programme Vera. Things changed radically for us in 2010. Out of the blue, I was diagnosed with a severe bilateral unprovoked pulmonary embolism with no signs of any DVTs or symptoms of DVTs. I'm a long-term warfarin user. I've been advised that DOACs are not suitable for me. And thanks to the support of Thrombosis UK, I now self-test. And things are relatively stable on that front. What I'm going to offer to do in the next 2 to 3 minutes is just offer a brief run-up to my diagnosis, then talk a bit about my emergency mission and recovery and where I am now. And I'm delighted to say things are so much better. Thanks to the support of some skilled health professionals and others. In terms of my run-up to diagnosis, I would describe myself as a 49-year-old, slightly overweight man at the time, who for 25 years had been a runner, up to marathon distance and had run competitively, cycled to work 13 mile there and 13 mile back, and swam a mile 3 times a week. I was very, very active and considerably lighter at different stages. So very active, no long-term, no flights, traveling or anything like that to predispose. But one morning I got into the pool and I couldn't swim to the end of the pool, 25 yards. I thought, that's not right. No other symptoms. Decided to get out the pool and I thought, shall I go to A&E? Because it was still, well, I was getting dry. Thought things are not right. And so I contacted my wife and I got an appointment with my GP almost immediately. So I went to GP, organised a chest x-ray, ECG normal, but chest x-ray showed that at an elevation in my diaphragm on the left-hand side. I couldn't lie flat without getting slightly dyspneic, so he referred me emergency referral through to a respiratory specialist, which I would be seen relatively quickly. I didn't make that appointment. It was 2.5, 3 weeks later. I was at home and suddenly felt drastically ill. And I felt my lungs suddenly took over. They started to behave in a different way. Very breathless, pale, looked in the mirror, had blue lips, legs felt wobbly, I felt nauseated. My wife is an accident emergency nurse. She didn't bother with the ambulance. We lived 2 minutes away in the car and I was straight into resus. I didn't collapse or have a cardiac arrest or anything like that, but I was tipping into respiratory failure, so things weren't good. So in terms of beyond that emergency admission, I was in hospital for 7 days and oxygen for 6 days. So it was a bit of a difficult experience. I went home and thought, how on earth am I going to get up those stairs? Because the breathlessness was still marked. Managed to totter around. Tried to do the best I could, but was unsuccessful. When the grandchildren come round to see us, I couldn't read the story, the usual Topsy and Tim story. I couldn't hold a telephone conversation for more than 3 to 4 minutes. And I took this mental attitude, well, it's just going to be hard work from here, set yourself targets. And I want to tell you straight away what that wasn't the right attitude. I thought I could rehabilitate myself through those early months. So recovery was incredibly slow. Had lots of difficult patches. After 6 months, I returned to work as an online learning specialist with a national cancer charity. And I started 2 hours a week. And it took me about 4 months to get to 10 hours a week. And I said to my boss, this is not working out here. And I basically resigned from my job and took a lower job in terms of responsibilities. But realised after a year things weren't right. Went to GP, was referred to pulmonary hypertension services, and they did their stuff on us and found that I still wasn't transferring gases, oxygen properly into my blood. My pulmonary pressures were still high. And there was obviously evidence that I'd had a degree of heart failure, right side heart failure in the past. So things weren't particularly good. And to top it all, the respiratory, the tests showed that my lung capacity for somebody my size and weight and age was 60% of what it should have been. So things weren't good. And I decided after 2.5 years to actually resign from work. I realised that Oc Health and I decided that full-time work was never going to be a possibility. And I left work to concentrate on me and seeing how far I could go. And the pulmonary hypertension team were brilliant. They said I was ready to start exercising. Went to the gym for the first time, which was a horrific experience when people 30 years older than you can knock spots off you on the bike or the treadmill. But actually, after a year, I lost 2 stone and started my first run of the park run. And I've done 226 since. So things have been gradually moved on. After a 16-month sabbatical, went back to work at Sunderland University, lecturing in the nursing and health department for about 10 to 14 hours, which changed with COVID. It got a bit more, but realised after 18 months ago, it was time to leave again. Life is so much better now. I'm in a good place. I can now read Topsy and Tim beginning to end to grandchildren. That's my benchmark. And once I started to connect with others and draw from the resources, Thrombosis UK, I realised I wasn't alone, and I got a better sense of what worked and didn't work, etc. I'm more active running. I walk and run now up to 50 miles a week, and really joined my running club. And 2 weeks ago, do paddleboarding, and I've really tried to live life more to the full. In terms of where I am health-wise, I'm still under the care of 3 specialists, the respiratory and sleep medicine team at locally I'm on CPAP. I also have an ongoing issue with bladder cancer, which has been successfully managed. And I also have a parotid tumor, which is monitored by a head and neck surgeon. So that's basically my story. And there's been lots of twists and turns, which I'll spare you the detail of, but things have turned out much better than I thought. It's not a happy ever after story, but it's been a difficult journey. But I'm glad to see that I've seen 2024. There was a point where I never thought I'd see 2024.
Thank you, Sean. That's really insightful, and it raises quite a number of issues that we hear from the things that you face, such as sharing information and coming to terms with the new things that you could or couldn't do that had been normal before or just seemed routine before. Can I turn to Paul now and just ask him, because I know you talk to a lot of people, and and I think sometimes this can be really difficult for anybody, but sometimes we hear more from men about this as well, that how you share that information and how you come to terms with the information, either with your family or perhaps with your employer, and you're facing the new you after a diagnosis and while you're in that recovery. comments can you make, please, Paul?
Thank you, Jo. And I stand in awe of Sean. I'm 220 park runs behind him. So that's, yeah. Thank you, Jo. There's some interesting issues happen when people, I always use the word interesting when I really mean pretty awful things happen when people have thrombosis. And if I can talk a little bit about the wider psychological impacts and then talk more about directly answer Joe's question or issue, if you don't mind. I mean, I think one of the really important things that we discovered, we've done some research looking at the psychological impact of a thrombosis. And what we found is that roughly half the people experience significant anxiety as a consequence of that. And that relates to a whole bundle of things. As Joe's pointed out, there's how do you manage the new you, the limitations you may have, the having to negotiate with work about health, without illness, talk to family, etc. And there's also, to be honest, there's that anxiety about what's going to happen to me. Is this going to happen again? And I think there's the psychology, and I am a psychologist, so I have to say this, but the psychology of the experience of thrombosis is complex, and there's a lot of issues, a lot of challenges to deal with. And I think one of the reasons for that is that, as Sean said, I mean, he was a very fit sort of person, doing essentially triathlon on a daily basis, which, and then suddenly out of the blue comes this event that is startling and frightening, at least potentially so. And what drew me into working with people with thrombosis is that those are the key things, that suddenness, the potential to life or perceived threat to life, and the unexpected nature of the event are enough to trigger in most people a normal reaction of anxiety for the future. Is this going to happen next? So on and so forth. And the fact that it's happened unexpectedly, even though people are on treatment, there's that fear of, well, if it's happened once, could it happen again? So there's a whole bundle of sort of anxieties that go along with this that are absolutely normal. They do recede in time, but often quite slowly, but they do recede in time. And then there's the challenges about, if you like, the new you, and Sean talked about, identifying goals, identifying sort of ways to negotiate and get a feeling of being a person again, being, in control of life. And a lot of the people that I work with, some of the things that we do is literally identifying what are the most important goals. If you can't do everything, you're more restricted physically. What are the really things that you want to achieve? What do you value? And then sort of developing a process of gradually working towards achieving those goals. And as someone who has knee arthritis, as Sean knows, and therefore struggles with running, sometimes you can't look back at what was I like, but it's that new baseline, but being positive and progressing and developing towards those valued goals. So there is quite a significant change and adaptation of coming to terms with what's occurred. I'm not going to talk about the specific issues about managing some of these psychological processes, but we have got some resources on the website that I'll come back to in a minute. But three of the really common psychological consequences of having the thrombosis are worry about the future, worry about how I negotiate, worry about going back to work, worry about will it happen again, and so forth. And that worry can be a sort of long-term debilitating thing that people catch themselves just just suddenly sitting there and suddenly being overwhelmed and being thinking, and that can lead to depression because
value goals, as I talked about before, may have to change and you can't achieve those. And some people even feel episodes of panic, particularly people that have had a pulmonary embolism, that have had chest problems. If they experience similar experiences to those that they've had, say, walking up a flight of stairs too quickly, can make people breathless, and suddenly you begin to think, oh, is it again? Is this what's happening? And people can get quite panicky. In fact, when we did some of the research, one of the people we talked to gave a name to this that we now use, and he called it post-thrombotic panic syndrome, which is that sort of panic that people, that sudden gush of, oh, what's happening? Am I having another recurrence? And so on and so forth. So there are multiple, if you like, natural responses to those. The key thing is each of those has a relatively simple means of sort of combating it. There are ways of combating panic. There are ways of managing worry so it becomes less problematic. There are ways of developing strategies to, set new goals, begin to sort of develop the new you in a positive and forward-looking way. Problem solving, looking at, as Joe said, how do I tell the family? Do I talk about my concerns? Men are typically very cautious about talking about the concerns they may have, but sometimes that can help, sometimes it doesn't. But thinking about all those sorts of issues. So if you go to the website, the Thrombosis UK website, which you clearly have, there is a sort of, I don't know what they're called, it's one of those little icons that can lead you to something called Regain. And within that Regain, there are a whole bundle of things about managing anxiety, managing sleep disturbances, worry, panic. And so those are resources that you can immediately access and read. And we're developing further ones of those as time goes on. But if people have even more issues that those don't resolve, then if people want to get in touch with me, Paul at Thrombosis, blah, 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 then I'm happy to do some one-to-one sort of chats to see whether we can work things through. Phew, that's me done. So thank you, Joe.
Thank you, Paul. We will come back to you and Sean with more questions, I'm sure, but I'm going to go to Dr. Will Lester now. And something that Sean raised, and we do hear from lots of people, men and women, but obviously focusing on men today, they're often very active in sport, and injuries may occur, or it may think they have an injury when it turns out it's a DVT. Are there any particular risk factors which men are more prone to, or also linking in with a question we've had, what are the risk factors for people to be aware of around blood clots?
I mean, so if we take all comers with DVT and PE, half of them is going to be essentially unprovoked. We're just not going to know, like Sean, we're just not really going to know what it was that was the trigger. There may be something really trivial, but we won't know whether that was relevant or not. So already half the people are in that boat of it's a mystery. For the other half, then, yeah, it's something. And in some ways for men, they don't have the exposure to risks like pregnancy and the pill. But they do have some slightly different risks in that, I muscle injury. So calf muscle tears do increase your risk of DVT temporarily. It doesn't mean that you're definitely going to get one, but it is a risk factor. And it's not an uncommon injury, especially someone who feels like they're a bit unfit and decides they're going to go out there and start going crazy, and and the muscles on, so that's one of the reasons for warm-ups and making sure that you're prepped. One of the things that tends to be more with men is the gym things. I mean, there's this enormous pressure now, especially for younger fellas, with the social media to look good, to bulk up and everything, and so there is this temptation, I guess, to take medications, steroids, that sort of thing, to bulk up, and some of those meds are prothrombotic. So I do ask people when I see them in clinic, I say, if you're going down the gym, have you been taking stuff? People don't necessarily want to admit it, but, it's useful for us to know, because if we know there's been a trigger, then that's good, because we can say, look, now we can start to explain what happened. And maybe if we avoid that risk in future and you don't take those meds again in future, maybe we could think about stopping anticoagulation. So it's really useful for us to know if there is something, even if you know, even if it's not something people necessarily want to widely admit. So yeah, the whole steroid gym thing is an issue, unfortunately, and it's it's the pressures that people are under, sort of to look, you know, to look good, I suppose. I don't know if that answers your question.
Yeah, no, it does. Thank you. And just sort of working on from that. So my understanding is when it's an unprovoked clot, most often the person is put on an anticoagulation for life. And there's often concerns about whether that's normal and is it safe to be on any of the anticoagulants. So it could be a DOAC or warfarin, or are there other health issues that they can develop because of that?
I mean, one of the first things I think that hits, and again, we're sort of talking about things that sort of tend to be more of an issue with men, I suppose, because that's what we're talking about today, isn't it? Is that having to take tablets for the rest of your life. That's a big burden for some people. Absolutely, it's like, you know, just it's just almost a deal breaker for some people. And you're not more likely to get a clot if you're a man than a woman, but once you've had a clot, your risk of getting another one is higher if you're male sex at birth. So if you've had an unprovoked clot, as in, you know, we don't know why, you will, over the next 5 to 10 years, if you decided that you don't want to take tablets because that's just something that you just cannot handle, your risk of getting another clot, ballpark risk, this is 40% over the next 5 to 10 years. And for a woman, it's slightly less than 30%. So there is a higher risk. So, you know, we tend to push a bit more with the fellas because we know their risk of relapse is higher. We don't actually understand the biology of this exactly, as to why that risk of relapse or recurrence off treatment is higher. But it does mean that we are pushing and arm twisting a little bit more because we know about that as a high risk. So, you know, if you know you've got a 40% risk of, well, ballpark risk of relapse over 5 to 10 years off treatment, it's quite high, you know. So most people are okay with the idea of taking tablets long term, but not everybody. I mean, I'm sort of going further to talk about lifestyle, I guess, now, but you know, there are certain things that are difficult to recommend in terms of safety. So once you're on anticoagulants, then you're trading your risk of relapse or further thrombosis against a slightly higher risk of bleeding. So there are certain things that I tend to recommend against. So anything where you're going to get punched or kicked in the head, basically. So kickboxing, boxing does not work well with anticoagulation. But then other things that are more intermittent, like skiing. So for some people, that absolutely their skiing holiday is, you know, if they've got enough money, their skiing holiday is a huge thing for them. And I suppose one of the advantages about the DOACs against warfarin, and I don't want to decry warfarin, warfarin's a fantastic drug, but has a good on-off effect. So I've had negotiations with people to say, look, you know, your risk of relapse if you come off treatment for 1 day or a couple of days or even a week is probably really low. And if you love skiing, you know, then, you know, don't take a tablet before you go down the slope. You know, we can, it's got a fast on-off effect, these drugs. So, you know, we can come to a compromise. So you can live the life you want to live with minimal risk. And, you know, I think that's that's why I think it's useful for people to see an expert in thrombosis to be able to talk about these things. I mean, there are lots of things to talk about in consultations, but that can be one of them, is about how, you know, how to compromise to get the best outcomes in terms of minimizing effects on things you love to do, but still keeping you safe.
Yeah, I think that also feeling a little bit back more in charge and self-help is so important to that recovery of regaining yourself. Going to self-help, some people obviously can't take a DOAC or haven't been prescribed it. They might be on warfarin. In general, if they're suitable, and I know that would come down to all sorts of, you know, assessments and things like that, but can they self-test? And in general, is that quite an easy thing, or how would they go about self-testing? And I don't know if on some of this, Sean might want to come in because I know he's been involved with.
Managed to organise it, and then I can make a comment after that.
I guess my journey to self-testing was driven by two things: about the convenience factor. Secondly, my wife was immunosuppressed, and during COVID, it was probably not wise for me to go into hospitals to be tested. So I approached Thrombosis UK in the first instance, and Joe and Claire were particularly helpful on the steps I would need to take. I approached my GP, who was in favour of it. He thought it was a great idea. My warfarin is managed by a hospital-based pharmacy service. I approached them and they were reticent. They were in the early stages thinking about self-testing. But I guess after a month or two, they agreed, and it's worked out really well. It's improved the quality of my life, and my control is so much better. So it's been a really positive. So it's about, first of all, ask advice of people who've been through the process of self-testing, and secondly, just think about who you need to approach and how you need to approach them. It took me about 3 months to sort out, but at the end of the day, it's been a good move.
Thank you, Sean. Well,
So, I mean, my personal feeling is that everyone on warfarin should have the opportunity to be able to self-test. But the problem we've had, and we almost managed to persuade, I think, NHS England to supply self-testing machines, but failed. So, I mean, there's good data for patients, say, with heart valves, because warfarin is given not just for thrombosis, DVTs and things, but also heart valves. That actually people who self-test, self-monitor have better outcomes. You know, so there's even good evidence that it actually improves outcomes. But the problem is that you have to buy the machine, and the machine costs about, I think it's something near 500 quid now. And you can pay in installments. You order it online, you can pay in installments to spread it out. But for some people, that's a deal breaker. You know, you're not going to spend £500 on a machine. Once you've got the machine, it's actually a lot easier because we can prescribe the strips. And actually, the companies make their money on the strips. They don't make it on the machine, they make it on the strips, and we can provide those, we can prescribe them. And so I say my feeling is anyone who can buy the machine, absolutely, I'm always supportive. There is a caveat, and that is that if you have triple positive antiphospholipid syndrome with something called a lupus anticoagulant, you have to make sure that you've had your INR tested by the vein and the machine, because occasionally for some people, if they're a bit unlucky, the machine gives you a bit of a dodgy result. So for those people, they have to have a venous INR, because these machines are finger prick testing. And so there's a very small this thing called a lupus anticoagulant where the machine it probably isn't suitable. So for anyone saying I want to go on the machine who's got antiphospholipid, let's do a dual test, make sure that the two test results are the same, and then they can go ahead. But yeah, it's a shame. I think that it's the having to buy the machine that's the problem. But I think taking control. You know, the more control you can take, the better. And then you could just email your result in. You know, you don't have to turn up to clinic or anything and get your email back. Yeah, so it's all good pretty much, I think, with self-testing.
yeah, I was certainly involved with some adolescents who were able to self-test, and that it worked brilliantly well. And it gave them a much freer, what they called normal life. And actually, there's a few questions come in about the strips. What I would suggest, because some of them are quite specific, is if you email in to admin@thrombosisuk.org, we can help you. We've got information, we can help you through how you either access them and whether they're available in certain areas and things like that. So just feel free to email and we can help you on an individual basis then. Talking about self-help as well, just after recovery, Sean mentioned it and we've had emails, questions in about pain. What is to be expected after a DVT and after a PE? And are there things that people can do to help overcome, say, the breathlessness or the pain in the legs and other things like that, the symptoms that they're suffering, and what should they expect?
Is that for me? Yeah.
Yeah, sorry.
So basically, DVT first. So if you've got a proximal DVT, as in knee and above, 50% of people are going to get long-term symptoms, and we call that post-thrombotic syndrome. Mostly, thank goodness, it's mild. For about 10%, it's more severe. And so it's not uncommon. You know, half of people are going to get some symptoms, and often it's a sort of, if it's mild, it's going to be like a bit of aching, a bit of pain, especially towards the end of the day, because it's a lot of it's gravity associated. So when you're walking and standing, and sometimes you can get pain that feels like the original DVT, but it isn't. if you've been doing a lot of exertion. And it tends to get better at night because you're horizontal, so there's no gravity pushing blood down your leg. And then, you know, if you get swelling of your ankles, often it goes down overnight and then reaccumulates in the day. So it's about trying to recognize what is your post-thrombotic syndrome rather than a new DVT. It is possible to get a new DVT whilst on anticoagulation, although it's not that common, but it can happen. So sometimes it's unclear. But I think if you do end up going back for a scan for whatever reason, there's a potential problem that they might scan you and go, yeah, there's a DVT there, but it could be the original one. Because if you scan a person's leg 6 months after they've had a DVT, about half of people have got residual abnormalities there. It's not clot anymore, it's residual scarring. And it's really important that it's someone, whoever's scanning is got the aptitude to be able to sort of recognize that this might just be old clot. Because once someone tells you you've had a second clot on anticoagulation, they're going to potentially be messing around with your anticoagulation, increasing intensity of anticoagulation, and that risk of bleeding. So it's really important to be absolutely certain that this is not post-thrombotic syndrome pain that you've experienced, rather than it being a new DVT. So it's really crucial to try, and there's no easy answer. Sometimes it's difficult, but I think one of the things that when I first see, I don't actually see people with VT until they're at least 3 months into their journey, which in some ways is a shame, because you want to be able to tell people these things right at the beginning, and often they don't get that information right at the beginning. But to say to people, you know, it's not up. You will get these pains on and off, especially towards the end of the day. The other one is the lung thing, and as Paul said, every time you get the sort of twinge or feel a bit breathless, it can trigger that sort of anxiety of, is this a recurrence? Am I going to die? And again, one of the things I say very early on in the consultation is it's normal to be feeling chest pains, because you often get left with a little bit of lung scarring from the original clots. And it's not unusual to feel breathless at 6 months, 3 months or 6 months. It's not unusual to get intermittent chest pains at 3 months and 6 months. And almost telling people that, you know, it's really reassuring that it doesn't mean there's a recurrence. And then we sometimes would then even start talking about strategies and refer on to psychologists or CBT to sort of say, how do you handle your emotional reaction to those sort of normalish symptoms? But again, you know, it is possible to have a new PE, but you would expect to have new pain that's very different. A significant worsening of breathlessness would normally be associated with a new PE. So yeah, it's about, and to some extent people learn themselves what is that normal for them, but to reassure them that the new pain does not mean new clot is really important, I think.
Okay, thank you, Will. There is another question which I'm going to direct to you as well. And I know we hear a lot about this. So people who suffer PTS and may use compression stockings to help the pain quite a lot, but can also suffer ulcers or risk of ulcers. What sort of self-help is there, or help from your doctor or medical team to try to reduce that risk and manage it well should they occur?
Yeah, I mean, you know, bad post-thrombotic syndrome is a real burden. And we used to think that if you wore compression socks for the first 2 years after your DVT, that it would reduce your risk of getting post-thrombotic syndrome. But then there was a trial done, the SOX trial run from Canada, that suggested that actually it doesn't. So there's not a definite early intervention that will definitely help. I think keeping your skin well moisturized with any sort of emollient, I think that's really important. And elevating your leg when you're sitting, so get a stool. It's a gravity thing, so get a stool so you can elevate your leg when you're sitting. For some people who have got bad post-thrombotic syndrome, we will refer on for more imaging. We don't normally scan everybody after 6 months with their DVT, because as I said, half of people have got residual scarring. It doesn't change management, but for some people with bad PTS, we might rescan, because what we're interested in is you might be one of those few people who have a blockage high up in the leg, which could potentially be amenable to some intervention. So very occasionally we might actually get our interventional radiologist to try and open up the blockage and put in a stent. You have to be really careful with these procedures because they can make your leg worse rather than better. So it's really important that people who really, really need it. But those, so we might go on and scan, and we might go on looking to see whether an intervention is required. That is the minority, I would say. So I think leg elevation, don't let your skin dry out, and potentially, have further follow-ups with your hematologist or your vascular specialist in order to assess as to whether further anything more needs to be done.
Okay, thank you so much. I'm going to go to Paul, because I know, Paul, you often talk with people who continue to feel breathlessness, and obviously panic can bring on and anxiety can bring on breathlessness. What advice do you have sometimes, where is there help that can address this, just to see if it's an emotional effect causing this physical symptom, and how to cope with that?
Yeah, thank you, Joe. I mean, although panic itself is very distressing, there are some very simple strategies that people can use to manage those initial stages. And the way that I often work with people is to sort of, coming back to a little bit of what Will was talking about earlier, it's learning what is the sensations that you experience, and learning what is normal for you and what is abnormal and unusual. And that can be quite a learning process of, over time, getting confidence in this is me and it's normal and it's not evidence of some highly traumatic issue. But the way that I look at it is there are some very simple strategies you can use. The driving force of panic is breathing. When people begin to get anxious, when people begin to get panicky, ironically, because the sensations are often in the lungs and the breathing anyway, people begin to overbreathe. And when you panic, it feels like you're having to control your breathing rather than your breathing is just naturally flowing. You feel short of breath, you feel you need more air, and so on and so forth. And what happens is there is a cycle of overbreathing begins to build up, and that overbreathing is actually associated with a whole bundle of symptoms. When people begin to do that, you can get tingling, you can feel lightheaded, you can feel literally difficulty in breathing. So it all sets off a whole sort of chain of worry and concern of what's going on, how do I manage this? But because breathing is central to that, there is actually a very simple strategy. There are more complex things you can do, but there is a simple self-help strategy that people can do, which is what various people call counting the box, counting the square, and it's essentially to slow your breathing down. So rather than just going, it's actually breathing in, and if you imagine a little box, breathing in 1, 2, 3, 4, holding your breath 1, 2, 3, 4, breathing out 1, 2, 3, 4, holding that exhalation for 1, 2, 3, 4, and literally just forcing the breath to become slower and more controlled. And that can be a very powerful way of reducing those early stages of panic. And I think, people say, well, part of the reason I'm panic is that I don't know whether these are, symptoms of an impending crisis, or they are, normal sensations or whatever. But the way that I think about that and talk to people is, if you delay seeking help for 10 minutes, quarter of an hour, that will have no impact on the quality of care that you get. When you've got to get to hospital, you've got to spend a quarter of an hour, 15 minutes, 20 minutes, maybe a few hours in casualties waiting to be seen. So 5 or 10 minutes just saying, right, I will assume that this is probably not an acute crisis, that if I can get my breathing under control, that I can become more relaxed, this will abate the problems I'm having, the experiences I'm having. And if I continue to have those after 10 minutes, quarter of an hour, then I may think about seeking help. So it's about giving that, not assuming immediately that there is a crisis, but giving yourself time to bring the sort of breathing under control, because then the symptoms begin to remit, you begin to relax a bit, and then move on. And it can take a while for that to happen, but yeah, it's a simple set of strategies that you can use. There's more complex stuff that we actually talk about on the Regain program. We've got some stuff, but yeah, simple breathing. Can I just make another comment, Joe, about in more general, if you don't mind? At the moment, I'm working with colleagues on developing some things about healthcare professional communication and how to do it and what to do it. And, you know, the point that is brought up not time and time again, but a frequent point is that, you know, when a healthcare person, pharmacist, nurse, doctor sees you, they're under a lot of time pressure. They've got 10 minutes, quarter of an hour, and they have a whole bundle of things that they need to do. They need to give information about this. They need to, you know, check various things, medication-wise, etc., etc. And what we keep emphasizing in that is the need for the patient to be pre-prepared with questions to ask to make sure that they get the issues they want addressed done in that consultation. Because Will is a wonderful, psychologically minded, patient-oriented. I'm just being nice to you, Will, at least smile, medic. But not all of them are. And, you know, it can be, you know, many people can go through a consultation without really bringing in that patient perspective. And, you know, we've talked about doing exercise. We've talked about doing some of the physical stuff that may be, you know, there may be risk associated in terms of bleeding and may be need to be dealt with. And if those are the issues that you need to deal with, be prepared. Go in there and say, I want to ask you about this quite early on, so the doctor knows that they or pharmacist or nurse or whatever, that they need to sort of adjust the time that they're spending and they can deal with those things. What you don't want to do is get to the end of that consultation and they say, right, okay, Mr. Jones, thank you very much, and thank you and goodbye. And you walk out without having dealt with those important issues. So just a response to some of the things that Will was saying about, you know, discussion of exercise and so forth.
I think Will might have a reply.
You know, thank you very much. I'm a sort of I don't know what you'd call it, like a pub trained psychologist. I give very bad, sort of rough, non-professional advice usually, but I try my best. So, yeah, I mean, let me give an example of a recent consultation that I had. So a gentleman who'd had a venous thrombosis, you know, 3 months earlier, came in with his partner and they sat down and they had a sort of very stony face. And I tend to sort of open up by just saying, how are you feeling at the moment? And then what tends to come in early in the conversation is like, you know, this event, what's happened to you is going to have a physical and it's going to have a psychological effect. You know, it's normal to feel absolutely floored by this. You know, it's like, you know, it puts you in the washing machine. It's, you know, I expect you not only to have physical symptoms, but you're probably struggling, and you could just see his sort of face just sort of collapse to just the acknowledgement of that. And then his partner said, oh, I'm so glad you said that, because he just won't talk to anybody. He won't express it. He's just bottling it all in. And I think, you know, just to try and allow people to feel that they can talk about what's worrying them. And I say maybe it's more of a bloke thing that we tend to avoid going to see healthcare professionals, and we bottle stuff up a bit more maybe. And so yeah, that was just one example really of just like, sometimes, you know, I suppose what I'm saying is if you acknowledge it to somebody, it allows them to sort of talk about rather than just talking at people.
Yeah, there's a wonderful quote that I came across some years ago, and it was, I'm paraphrasing it slightly, I suspect, but it was, if a man says, I haven't been to the GP for 20 years, they're making a statement about their health and their masculinity. You know, men do not talk about these sorts of things. And that actually has quite a bad outcome. You know, men are often in a different context of heart disease, heart attacks, You know, men have quite bad outcomes of heart attacks often because they don't seek help, you know, or they delay seeking help. So it is important to not to go absolutely counter to your normal way of coping if it is to be stoic and solid. But I think it is important to talk about some of these issues and how you feel, so that both the person you're consulting with is aware of that and can perhaps allay some of those anxieties, but also to talk with people around that actually these are what's going on, because they are absolutely normal. If you are not anxious following had a significant thrombosis, you would be frankly weird. You know, it is a frightening, potentially significant effect. So to acknowledge that and to talk about it can be quite important sort of thing to do. So yeah, don't keep quiet.
Thank you, that's brilliant. And Sean's waited so patiently with his hand up.
That's
I
okay.
want to come to you, Sean, as well, because you've obviously experienced this, including the pain and the breathlessness. And there have been questions around how did you tackle going back and coping and overcoming some of those physical symptoms and fears in your recovery?
Yeah, thanks, Joe, and thanks, Paul and Will. I think just the comments you made were just so helpful. And I remember about 4.5 months post PE, I didn't know what was anxiety. I didn't know what was, if that anxiety was drying the breathlessness. So I referred myself to talking therapies. And I just basically said, I just need some help to really understand what's happened here. And I know that you're not an expert in thrombosis, but I'm led to believe you have some expertise in help me sort my head out. And that's in essence. And there was two stances. First of all, they did some work on mindfulness and helped me understand anxiety and also understand my thinking about the whole experience. And can I say that was a turning point? Things didn't improve with the symptoms of breathlessness. There were reasons underneath that. But I realized that I could actually interpret that in a different way. Rather than turn up at A&E or my GP, I could make sense of it. And that was a real turn point. And can I say that panic was part of my experience? And I had an unusual panic attack actually 6 years later. I was on my way to give a lecture to a group of healthcare professionals in one of the trusts. And for some reason, I thought, what the heck's going on here? Came on, you know, where's this come from? And rather than send them a sick note, I'll not be there, or this sort of thing, I just actually sat on a bench and rehearsed some of the things I'd been taught by the talk and therapies team. And I went in and everything was fine. And I was really pleased with myself, and nobody saw that. But the way I coped was, first of all, acknowledging as a man, it's okay to be anxious. It's understandable. And I needed help because I couldn't do it myself. The self-help wasn't working, and it's understandably so. And I think second thing is about, I guess, expressing your preferences and starting to talk with those people that are around you. So you're not trying to do the normal like you used to and put yourself under unnecessary stress.
Thank you, Sean. That is really helpful. Will, can I come back to you a little bit around self-help again, really, about how we can help reduce risk and also recover beyond the medication? Obviously, the medication is really important, but are there things that people can do to help themselves in other ways as well?
Yeah, absolutely. I mean, you know, we all want to be able to sort of control, don't we? Have some control over what's happened to us and our futures. And a common question, which I often disappoint people with my answer, is there a food that I can eat that's going to basically cure this? You know, and that question gets asked about nearly every blood disorder that exists. You know, like if I have some more turmeric, am I going to be all right? That sort of thing. And my advice is, look, you know, you can't beat a healthy, balanced diet. You know, moderation, don't have excess of anything, particularly a good, healthy diet. I would say the biggest difficulty for patients, for all of us, and especially people with VTE in this context, is weight. So if your BMI is over 30, it gives you the sort of equivalent increased risk of thrombosis as a common genetic mutation called factor V Leiden. So 1 in 20 people carry this thing called factor V Leiden. And And often people are very worried about it, but on its own, it's relatively weak risk unless it's paired with some other things as well. But it is a risk factor, and a BMI over 30 is a pretty equivalent. So
can I interrupt for one moment and just say, please, could you use your microphone, because it's just a little bit, it's getting a little bit faint.
Forgot about that. So BMI over 30 is equivalent to factor 5 Lardin, which is a genetic risk factor, and it's really hard to lose weight, and especially if you're in that cycle where you've had a DVT or PE, you're not back up to full activity levels, and it's sort of, how can I lose weight when I'm less active type of thing, because you're trying to, we encourage people to build up their activity levels, because sometimes people are scared to push themselves, and I, as long as I've ruled out stuff like pulmonary hypertension and things, that Sean actually had a bit of that, but so I sometimes echo people, as long as I'm happy that there's no issues, I'll say, you can push yourself, you're not going to drop down dead if you push yourself. But that's a slow process, and so people tend to put on weight often early on in their VT journey because they're less active. So, the discipline it takes to lose weight when you're less active, calorie control is really difficult, but it will help. So, if you can do it, then it will help. If you can get your BMI below 30, that is good. But I acknowledge it with people when I say it. I say, this is really, this is difficult, but if you can do it, do it.
Thank you. And does that go also into exercise, even if it's walking? It doesn't have to be highly intense if it's at your level, but
I think people think maybe they've got to do some sort of like weights or something like that. I mean, what is best is aerobic exercise, just walking, maybe exercise bike and that sort of thing, not you don't have to go crazy. And it is a slow process of getting there's two things that happen, say, with a PE. You get the PE itself, you get the effect of the PE, the post-PE syndrome, but you get deconditioned. Your activity level dives, and it takes ages to get it back, basically. So fighting deconditioning is almost, is more of an issue almost because of your dropped activity levels than actually the PE itself in terms of what it's done to your lung. So yeah, absolutely push it. Just be patient with yourself and just walk a bit more each day as much as you can tolerate. And yeah, it's exercise is really important. Even in the absence of weight loss, exercise has been shown to improve people's general outcomes. So it is, it's almost a separate thing.
okay, brilliant. Thank you. Can I go to Sean again? Sean,
Yeah.
how did you just begin to start your exercise regime going back? Because it's something I think, well, I certainly would find very hard.
Yeah, I think just to pick up on something Will offered there, which was really helpful, I experienced deconditioning. And as a result, before I actually had to go for surgery twice, 4 years post pulmonary embolism, and they did some testing on us. And can I say, it was really good because they gave us a confirmation that my ability to use oxygen in the body had improved again. And that was tremendously reassuring. So it actually reinforced the fact that that walk and gradually moving into running and cycling again slowly actually had a positive effect. And that reassured us moving forward. But where did I start? Well, first of all, I started and failed. I tried too hard too quickly. I thought I could, just work hard and it'll get better. And somebody gave me a book called Turnaround Toughness. And as a macho bloke, I took it to heart and I thought, well, I'll just do what they say. But actually, it turned around failure because I just couldn't meet those expectations. And as Will mentioned, you just need to be patient with yourself. And you know instinctively the way to go. The next step, as I built up, I was frightened of being breathless again. I genuinely did never want to be breathless like that way again. And my daughter said, "Do you not fancy the park run?" And I said, "No, I don't want to be breathless again." And they just smiled. And as it happened, I thought about that, and I started again and started getting breathless by gently jogging. And I found that I wasn't collapsing. I didn't need to go in A&E. Everything was fine. And so I just gradually built up. And I realized I could get faster. And I could hold that breathlessness for a longer period of time. But I also found that if I tried too hard, I was ill. As something I hadn't experienced before, I felt sick and fatigued. And I think given my history with, you know, the pulmonary hypertension team, that can be explained, but that has now gone. And I think third is almost have your 70-mile-an-hour speed limit. You know, you're in the motorway and it says this has got a speed indicator. Don't go any past that. Just find out what that limit is. And I think fourth is do something different. If it doesn't work, I was always used to run because I could get wherever I want to do faster. But I've actually really enjoyed running. As a result, I take a camera now. I take pictures, I stop, and I talk to somebody on the journey. There's a lot more pleasures in doing something different. I never would have imagined I would be the type of guy that do that. And I think is maybe set some goals, as Will said, that combination of the diet and exercise together. You realize the new normal isn't as bad as you thought. So don't try to put that pressure on yourself to return to where you were and to see what happens.
Thank you so much. We've only just a couple of minutes left. So I'm going to go to Paul. Paul, for anybody who's listened to this session, but still would like more information or struggling perhaps with the coping of this, what advice or where can you signpost them to?
Yeah, can I just emphasize, sorry, I know time's beating us, but I think one of the things that is crucial is that setting of new goals based on where you are now. That sort of reflection back, I've been through this for other reasons, but I used to be able to run X speed is pretty destructive. I think it's almost setting a baseline for where you are now and looking for improvement beyond that. And I think that is that not harking back, but this is where we start. But with the optimistic expectation that things will improve, I think is absolutely crucial. Just to echo what Sean was saying, really. In terms of resources for the psychological side of things, if you go to the website, there is a tile. I've remembered the name for it now. There is a tile on the website, quite a big one, to something called the Regain program, which is essentially providing psychological support to people that have had thrombosis of all sorts. There's people here that have had post-COVID vaccine. We've been providing support with those, and now we're developing it further for other thromboses. If you go there, there are some self-help leaflets, managing anxiety, managing panic, managing worry, that give you strategies about how to deal with these things. But if people go and they think, yeah, these are useful, but haven't quite gone there, then if people contact me at paul@thrombosisuk.org, I think I've got that right, Joe, then we can set up a one-to-one and have a chat through some of the specific issues that people are experiencing, and go from there to look at some sort of further strategies that people can use.
Thank you, Paul. And I think for last comment, can I go to you, Will, about sort of takeaway messages from a diagnosis of VTE?
I don't think any one takeaway message other than I think a lot of people have got a lot of questions, and I really hope that they would have access to some local service where they can ask their GP to be referred to a thrombosis clinic if they haven't already got a thrombosis clinic that hook up already, because there are people out there who can you can talk to if you really feel that you've got these burning unanswered questions. Most regions will have thrombosis clinics available.
Okay, thank you so much. And also, if any questions you had or you weren't able to share here today, but you come to mind afterwards, please do email into Thrombosis UK, and wherever possible, we will do our best to get an answer or signpost and share information with you. So please never fear, just send that email in and Claire, Anya, or myself will respond to you. Thank you so much to our panel, to Sean, Paul and Will. This has been a really, I think, positive and uplifting conversation, actually, raising many interesting and important points. Thank you to everybody who attended. I hope you found this valuable as well. We'll have to close it now, but we will be advertising soon for next sessions and to hopefully repeat similar ones from any of your feedback. So thanks very much. Okay, bye-bye.